Patient's here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. We are so glad you're here with us today.
It's great to be here.
We are stepping into what I honestly think is one of the most high-stakes, high-pressure, but ultimately rewarding environments in all of medicine.
Oh, for sure.
Imagine walking onto a pediatric unit. It's colorful, right?
Yeah.
Maybe there are cartoons on the wall, the nurses are wearing these fun scrubs. But underneath all that cheerful aesthetic, there is this incredible, palpable tension.
There is.
Because kids are not just small adults.
That is the absolute first rule of pediatrics.
Yes.
It's the mantra.
Yeah.
If you walk in thinking a child is just a miniature version of a 40-year-old, you're going to miss things.
Big things.
Vital things. They are an entirely different physiological species in many ways. Their metabolic rates are different, their compensatory mechanisms are different, and the way they crash is really, really different.
And that is exactly what makes the source material we are covering today. Chapter 10, the Pediatric Health Assessment, so incredibly daunting.
It's a beast of a chapter.
It really is. I was looking through the notes, the textbook excerpts, the lecture slides you send over, and it feels like an avalanche of disconnected details. You have to know growth charts and obscure reflexes, weird skin spots, specific timelines for fontanel closures, and somehow you have to do it all while a 3-year-old is screaming at the top of their lungs and kicking you.
It is the definition of information overload. And for a nursing student or, a new grad, the risk is real. You get so bogged down in memorizing the circumference of a 6-month-old's head or the exact month a reflex disappears.
Right, you get lost in the weeds.
You do.
Yeah.
And you might miss the fact that the toddler across the room is in respiratory failure. You completely lose the forest for the trees.
Exactly. So we are going to do something different today. We aren't just reading the chapter.
No.
We are applying the Pareto principle, the 80-20 rule.
Which is my favorite way to approach complex medical topics. It just cuts through the noise.
It does. And the idea is simple. 20% of the information gives you 80% of your results. And in the context of nursing, results mean 2 very specific things.
Okay.
First, passing your exams, because the test writers love to trap you on these specific developmental nuances.
Oh, they love it.
And second, honestly, the only one that really matters in the real world, keeping that child safe.
That's the bottom line. So what we're going to do is separate the need to know, the safety critical high yield exam stuff from the nice to know.
The fluff.
Yeah, the context and the fluff. We are turning this textbook into a survival guide.
I love that. A survival guide. So we're going to walk through the assessment head to toe, but we're filtering every single step through the lens of exam traps and clinical red flags.
Exactly.
If you're a student cramming for a midterm or a new grad who's terrified of your first shift, this is your blueprint.
Let's dive in.
Okay, so take us into the room. The source material starts with the general survey, but it makes a really interesting point immediately. It says the most important part of the assessment happens before you even say hello.
Right.
Before you even touch the patient.
This is what we call the door handle observation. This is our first big need-to-know 80-20 core concept.
The door handle observation. It sounds like a spy novel technique. But tell us why this specific moment is so critical.
It is critical because of, it's essentially the Heisenberg uncertainty principle of medicine.
Okay, you're going to have to break that down for me.
The moment you walk into a room and engage with a child, you change the data. You change the dynamic.
You're a variable.
You're a huge variable.
Yeah.
If you rush in, they might start crying, which immediately changes their heart rate and their respiratory rate. Or they might perk up because of the stimulation, masking how lethargic they really were just a second ago.
So you need the baseline.
You need the unadulterated baseline. It literally means you pause with your hand on the door handle or just as you step inside the threshold and you look.
Just look.
You do not rush in with your stethoscope. You don't introduce yourself yet. You just observe.
And what exactly are we scanning for in that split second? It can't be everything.
No, it's very targeted.
Yeah.
You are looking for the pediatric assessment triangle. It's a rapid visual scan of three things: appearance, work of breathing, and circulation to the skin.
Appearance, work of breathing, and circulation.
This is your need-to-know foundation. Everything else is built on this.
Okay, let's unpack those because appearance sounds a bit superficial. We aren't judging their outfit or if their hair is combed.
No, not at all. Appearance in this context is entirely neurological. It's about tone, interactiveness, and consolability.
So what does that look like from the doorway?
Looks like? Is the child tracking you with their eyes as you walk in? Are they moving spontaneously? Or, this is a scary one, are they limp? Are they floppy?
Like a rag doll.
Exactly.
Yeah.
Are they staring into space with a glazed look? If you see a floppy baby from the doorway, or a toddler who isn't reacting to a stranger entering the room, you aren't doing a health history.
No, you're intervening.
You are calling a code or shouting for help. It's that serious.
So appearance equals brain perfusion. Got it. What about work of breathing?
You're looking for the struggle. Before you even think about putting a stethoscope on their chest, can you see them breathing from 10 feet away?
And what would that look like?
Is the chest heaving?
Yeah.
Are they sitting in what we call a tripod position, leaning forward with their hands on their knees just to get air in?
I've seen that.
Yeah. Are their nostrils flaring with every breath? If you see the work, you know there is pathology before you even hear the breath sounds.
And finally, circulation.
This is color. It's that simple. Are they pink? Or are they pale? Are they mottled, which looks kind of like a web-like lacy pattern on the skin? Or are they blue?
And if you spot a problem in this door handle phase...
The routine exam is over. It's done. You intervene immediately.
Okay, so assuming the door handle observation is stable, the kid looks okay, they're breathing fine, we move in. Now, I found a massive exam trap in the notes regarding the order of operations. In adult nursing, we are trained to be robots, head to toe, every time. Systematic.
And if you do that with a child, you will fail. You will absolutely fail.
Why? Why does the system just completely break down?
Because children are volatile. Their mood is a ticking clock. The sources emphasize that with kids, you have to be an opportunist. It's another classic need to know.
Be an opportunist.
Exactly. If you walk in and the infant or toddler is sleeping, or they're just quiet on the parent's lap, what is the very first thing you do?
My adult nursing brain says, wake them up gently, introduce myself, get a weight, get a height.
And that is how you fail the simulation, and how you make the next hour of your life miserable.
Brutal. Okay, correct me. What's the right move?
If they are quiet, you listen, you get your stethoscope, and you get your auscultation done, heart and lungs, while they are calm. Because the moment you wake them up to weigh them, or put them on a cold scale, or look in their throat with a tongue depressor, they will scream.
And then you can't hear anything.
You can't hear anything. And I defy anyone to hear a graded 2 heart murmur through the chest wall of a screaming, kicking toddler.
Yeah.
It's impossible. You've lost your data.
So the rule is least invasive to most invasive.
Always. That is the core principle. You listen first. You might touch the belly next. That's usually okay. You save the ears, the throat, and anything involving a needle or a probe for the grand finale.
Because once you lose their trust...
It's gone. You don't get it back in that visit. You have to earn the right to do the painful or scary stuff by doing the easy, quiet stuff first.
That actually leads us perfectly into the developmental stages. The approach changes completely depending on the age. The source material highlights the no phase for toddlers. This is ages, what, 1 to 3?
Yeah, 1 to 3. Toddlers are fascinating and so frustrating because they are defined by egocentrism. That is the developmental keyword you'll see on exams.
Egocentrism.
They want autonomy. They just discover they are separate people from their parents, and their favorite word is no. So if you ask a toddler, can I listen to your heart now, or is it okay if I check your tummy? What is the answer always going to be?
It's going to be no. A very loud no.
Even if they aren't scared, they'll say no just to exercise that power. They are testing their boundaries with you.
So how do you get consent without asking a yes-no question? I mean, we can't just tackle them.
No, definitely not. You use what we call forced choice or just direct statements. You don't ask permission for the necessary things. You say cheerfully and firmly, I am going to listen to your heart now.
Just a statement of fact.
A statement of fact. Or if you want to give them some control, which they crave, you say, do you want me to listen to your heart first or your teddy bear's heart first?
That's clever. You give them a choice, but neither option is no, get away from me.
Exactly. You frame the interaction so that compliance is the only outcome, but they still feel like they participated. They got to make a decision. And location matters. For a toddler, the exam table is lava. It's a scary, cold, high-up place. Do not put them up there if you can avoid it.
So where do you do the exam?
On the parent's lap. The parent is their safety anchor, their home base. Use that to your advantage.
Okay, moving up to preschoolers. These are the 3 to 5-year-olds. The notes mention they have vivid imaginations, which sounds cute, but in a hospital, it sounds terrified.
It is terrifying for them. Their cognitive development is heavily based on magical thinking.
Magical thinking.
Yeah, they don't understand cause and effect properly yet.
Right.
They think thoughts can cause reality. And the big fear here, and this is a specific term in the literature you need to know for your exams, is fear of mutilation.
Fear of mutilation. Wow, that sounds incredibly intense for a 4-year-old.
It means they have really poor body integrity concepts. They view their skin as a balloon that holds everything inside.
Okay.
So if you give a preschooler a shot, or if they get a cut, they genuinely worry that all their insides, their blood, their guts, are going to leak out through that one tiny hole.
Oh, wow. So that's why a tiny paper cut is the end of the world.
Exactly. And that's why Band-Aids are like magic spells to them. It seals the leak. It holds them together.
So for the exam, how do we mitigate that fear?
You have to demystify the equipment. Let them handle the stethoscope. Let them press the button on the thermometer. If they can play with it, it stops being a weapon and starts being a toy.
Make it familiar.
And you explain things in their language. This is going to give your arm a big hug for the blood pressure cuff, not this is going to squeeze you really tight. Language matters so much at this age.
Then we hit the adolescents, teenagers. The vibe shifts here completely. We aren't dealing with fear of monsters anymore. We're dealing with fear of judgment.
The priority shifts to privacy and body image. Adolescents are hyper-aware of their changing bodies, and they're mortified by pretty much everything.
The source material says we should offer to have the parent step out. That feels tricky if the parent is hovering or insists on staying.
It is tricky, but it's necessary to offer it. You can say something like, okay, for this part of the exam, I'm just going to ask some routine questions. A lot of teens prefer to do this part privately. Mom, would you be comfortable stepping out for a few minutes?
And what if mom says no?
You have to respect that, but you document it, and you know you're probably not getting honest answers. Adolescents will not answer questions about substance use, sexual activity, or depression, honestly, if their mom is sitting right there.
So you have to try to create that safe space.
You do. But, and this is a huge legal and ethical need to know, you have to establish the boundaries of that privacy up front.
The safety limit.
Right.
Yeah.
You cannot promise total secrecy. New nurses often make this mistake. They say, I won't tell anyone anything, I promise.
And that's a problem because...
If you do that, and then the teen tells you they are suicidal, you are in a legal and ethical bind. You have to break your promise.
So what's the script? What do you say?
You have to use the phrase, everything we talk about is private and confidential. Unless you tell me someone is hurting you, you want to hurt someone else, or you want to hurt yourself. In those cases, my job is to get you help and keep you safe.
That's the distinct line. You are a vault up until lives are at risk.
Correct. If you don't say that disclaimer up front, and then you have to report them to protect them, they will feel betrayed, and you've lost that therapeutic relationship forever.
Okay, that makes total sense. Before we leave the general survey, let's hit a couple of those nice-to-know supporting info points from the notes. These are the things that make the exam smoother, but aren't necessarily life or death.
The art of the exam, not just the science.
Exactly. Building rapport. The expert notes suggest ignoring the child at first.
It sounds so counterintuitive, right?
It does. I want to be friendly. I want to say hi to the kid.
But think about it from the kid's perspective. You are a giant stranger in a weird uniform. If you rush at them, you're a threat. If you ignore them and talk calmly to the parent, the child watches.
They're observing the interaction.
They see the parent is calm. They see the parent trusts you. It's what we call a social proxy.
It's like when a dog looks at its owner to see if a new person is okay.
It is the exact same mechanism. Once the kid sees mom is cool with you, then you can slowly engage. Get down on their eye level, don't tower over them like a giant, and use a transition object.
A transition object? What's that?
A puppet, a toy, a light-up pen. Something to bridge the gap between your scary medical world and their world of play. You examine the puppet's heart first.
I like that. And lastly for this segment, family history. The notes mention something called a genogram.
Right. A genogram is basically a family tree, but for medical issues. In pediatrics, we really want to go back 3 generations if we can.
Why 3?
We were looking for patterns: early heart disease,
Yeah.
genetic traits like sickle cell or cystic fibrosis, sudden unexplained deaths. It gives us the genetic context for the child sitting in front of us. It's nice to know for the immediate physical exam, but it becomes need to know for the long-term plan of care.
Got it. Okay, moving on to segment 2, vital signs and measurements. This seems straightforward, numbers are numbers, but I feel like there are some math traps here, specifically with blood pressure.
Oh, this is a huge one. This is our next big need-to-know 80-20 core, the blood pressure cuff Goldilocks rule. I cannot stress this enough.
Okay, lay it on me, the Goldilocks rule.
Most people, they just grab whatever cuff is on the wall. A pediatric cuff, that looks about right. That's so dangerous. The accuracy depends entirely on cuff size relative to that specific child's arm.
So what's the rule?
The rule is the bladder width of the cuff, that's the inflatable part inside, should be approximately 40% of the circumference of the upper arm.
40%. Okay, that's very specific. But what happens if we mess that up? This is the physics question that always appears on tests.
Right. So if the cuff is too narrow, meaning it's too tight or just too small for that arm, you will get a falsely high GH reading.
A falsely high. Why is that? What's the mechanism?
Think about the mechanics of it. To stop the blood flow in a big artery with the tiny little cuff, you have to pump it up way harder to compress all the tissue deep enough to pinch that artery shut.
Okay.
The machine reads all that extra effort, that extra pressure, as higher blood pressure.
That makes perfect sense. So too small equals artificially high pressure.
And the opposite is also true. If the cuff is too wide, too loose, or just too big, you get a falsely low W reading.
How does that happen?
It distributes the pressure too easily over a larger surface area, so it stops the blood flow with less pressure than is actually inside the vessel. It's like trying to stop a river with a bedsheet instead of a focused dam.
Wow. I can just see a new nurse panicking over a high BP, calling the doctor, maybe even starting meds, all because they used the standard pediatric cuff on a chubby arm that really needed a small adult cuff.
It happens all the time.
Huh?
And conversely, you could miss hypotension in a really sick, shocky kid because the cuff was too big, and you think their pressure is fine when it's really in the basement.
The lesson is, always check the cuff size before you treat the number.
Always.
Let's talk pulse oximetry. We stick these on kids all the time. Is there a trick to it?
The trick isn't the application, it's the validation. This is a big need to know. Kids wiggle a lot.
True.
If a child is waving their hand around, the sensor's picking up motion. You might look at the monitor and see a saturation of 85% and a heart rate of 60. But the kid looks pink and happy and is breathing fine.
So the monitor is lying.
The monitor's confused. You have to check the waveform. You need to see a good, strong pleth wave, that's the little squiggly line, that matches the child's actual heart rate.
So you cross-reference.
You have to. If the monitor says the heart rate is 60, but you listen to the chest and the heart is actually going 140, that saturation number is garbage. It's artifact.
So the saying is true. Treat the patient, not the machine.
That should be tattooed on every nurse's arm.
Seriously.
And one more thing on pulse ox probes. The adhesive ones. You have to rotate the sensor site every few hours. And infant skin is so fragile, you can cause a pressure ulcer or a burn from that little red light if you leave it in one spot for too long.
That's a great practical tip. Now, growth charts. I remember seeing these. It's a lot of curves and percentiles. It can be overwhelming.
It can. The need to know here is simple. A single point in time is almost meaningless. We care about the trend.
Explain that. What does that mean in practice?
Okay, so a child comes in and they are in the 5th percentile for weight. Is that bad?
It sounds low. My gut reaction is yes, that's bad.
It is low. But if they've been in the 5th percentile since birth and their parents are both very small, petite people, that is their normal. They're growing along their own curve.
So it's about consistency.
It's about their own personal trajectory. That is likely their genetic potential. We don't worry about that kid.
So when do we panic? When do we start the workup?
We panic at deviations. We worry when a child who is tracking along the 50th percentile their whole life suddenly, at their 2-year checkup, drops to the 10th percentile. That is called falling off the growth curve.
And that signals a problem.
That signals a big problem. That means something is wrong. We start thinking failure to thrive, malnutrition, or a chronic illness that's just starting to show itself, like celiac disease or cystic fibrosis.
So it's the deviation, not the destination. That's the red flag.
Precisely.
Any quick, nice-to-know points on measurement logistics from the source material?
Just a few practical things. Weigh infants nude. A wet diaper can weigh a significant amount relative to a tiny baby. You don't want to document urine as weight gain.
That's a good point.
And for height,
Yeah.
Children under 2, or those who can't stand well, are measured lying down. We call that recumbent length. Once they can stand reliably, usually after age 2, we switch to standing height. And we measure head circumference until age 2 or 3 to screen for things like hydrocephalus or microcephaly.
Okay, let's move to segment 3, the skin. This feels like detective work. The skin is on the outside, but it tells us what's happening on the inside.
It's the billboard for the body's systemic health. And the biggest, scariest need to know here is distinguishing between birthmarks and abuse. This is a high-stakes area.
This is crucial. The source mentions Mongolian spots.
Yes, the formal name now is congenital dermal melanocytosis. These are dark, bluish pigmented patches, and they usually show up on the lower back, the buttocks, or the shoulders.
And they're common.
Very common, but specifically in darker-skinned infants. So infants of Black, Asian, Hispanic, or Mediterranean descent. You don't see them as much in fair-skinned babies.
And the problem is they look exactly like bruises.
They look exactly like deep old bruises. I have personally seen parents get accused of abuse by well-meaning but uneducated providers who didn't know what these were.
That is an absolute nightmare scenario for a family.
It is. The exam trap and the clinical safety tip are the same. If you are the admitting nurse, you must document these immediately. Measure them, photograph them if your policy allows, describe their location and color.
Why is that first documentation so important?
Because if you don't, and a different provider sees them 3 days later, they will assume they are new injuries acquired at home or in the hospital. Your initial note protects the family.
So documentation is the shield. On the flip side, what does actual abuse bruising look like?
We have a rhyme for this, and it's grim, but it is very effective. Those who don't cruise shouldn't bruise.
Those who don't cruise shouldn't bruise, meaning if the baby isn't walking yet.
They shouldn't have bruises. A 2-month-old cannot roll over and bump into a coffee table. A 4-month-old cannot fall off a swing set. If you see ecchymosis, that's the medical term for bruising on a non-mobile infant, especially on the torso, the ears, or the neck. That is a major red flag for non-accidental trauma.
A red flag that's waving violently.
Exactly. That requires an immediate, careful, and thorough investigation.
That is a chilling rule, but very easy to remember. Let's talk about color changes as distress signals. We hear cyanosis and we think blue, but there are nuances here.
Yes, we need to distinguish central cyanosis from acrocyanosis. This is a classic exam question, a need to know for sure.
Okay, break it down for us.
Central cyanosis is blue lips, a blue tongue, blue mucous membranes inside the mouth. This is the core of the body. It means the blood pumping out of the heart is not carrying enough oxygen. This is true hypoxia. It is an emergency. You run.
Got it. Central is bad, and acrocyanosis.
Acrocyanosis is blueness of the hands and feet. The word acro means extremity. This is actually considered normal in newborns for the first 24 to 48 hours.
Normal. Blue hands are normal. That seems so counterintuitive.
It does, but yes. Their peripheral circulation is still very immature. The body is smart. It shunts the warm, oxygenated blood to the vital organs, the brain, the heart, the kidneys, and it clamps down on the circulation to the hands and feet. So they're often cool and a little bit blue.
So if a new mom frantically calls you over and says, "My baby's hands are blue," you don't call a code blue.
You don't. You calmly reassure her. You say, "That's very normal for a new baby. Let's put some socks and mittens on him to warm him up." But if she says, "His lips are blue," you hit the emergency alarm.
The location of the blue makes all the difference. What about jaundice? The yellowing of the skin.
Jaundice is all about timing. It's a clock game. This is another core concept.
The clock game, okay.
If a baby turns yellow in the first 24 hours of life, on day 1, that is always considered pathological. That is bad.
Why? What does that mean?
It usually indicates a rapid destruction of red blood cells, maybe from a blood incompatibility between mom and baby, like an ABO or RH issue, or a liver problem. That baby needs an immediate workup.
And if the jaundice appears after 24 hours?
If it appears after 24 hours, so on day 2 or day 3, it's much more likely to be physiologic jaundice. It's very common. It just means the newborn's liver is immature and can't process the breakdown of old fetal red blood cells fast enough. We monitor it. We might use phototherapy lights, but it's not the immediate crisis that day 1 jaundice is.
So yellow on day 1 equals red flag. Yellow on day 3 equals watch and wait.
You got it.
Any quick, nice-to-know points for skin from the chapter?
Turgor. Yep, Turgor checks for hydration. In an adult, you usually pinch the skin on the back of the hand. In an infant, that's not reliable. You pinch the skin on the abdomen.
On the belly.
Right. If the skin tense, meaning it stays stuck up in a little tent shape after you let go,
Yeah.
that's a sign of moderate to severe dehydration.
And what about common benign lesions, the stuff parents ask about?
Right? Is this normal? Questions. Stork bites, those are the pink spots on the back of the neck or eyelids. Strawberry hemangiomas, the bright red. Raised marks that grow for a while and then usually shrink by school age. And melia, those little white bumps on the nose. Tell parents not to pop the melia. They're just clogged oil glands and they go away on their own.
Segment 4, heat. Head, eyes, ears, nose, throat. We have some heavy hitters in here. Let's start with the fontanelles, the soft spots.
The fontanelles are brilliant design features, really. They allow the skull bones to overlap so the head can fit through the birth canal, and then they allow for the incredible brain growth that happens in the first year. But for us, clinically, they are windows into intracranial pressure.
Windows into the brain. We have two main ones, right?
Correct. The anterior fontanelle, which is on the top of the head and it's diamond-shaped, and the posterior one, which is on the back of the head and it's smaller, more triangular.
And they close at different times.
Vastly different times. This is a need to know. The posterior closes really fast, by about 2 months of age, but the anterior stays open much longer, usually until 12 to 18 months.
So what are we feeling for when we touch that soft spot?
We are feeling for pressure. We're assessing hydration and intracranial pressure. So if the fontanelle is bulging, if it's tense, hard, and popping out above the skull, that indicates increased pressure inside the skull.
And we should be thinking what?
We think of scary things, meningitis, hydrocephalus, maybe fluid overload from an IV. It's a sign of a serious problem.
But the notes say crying affects this. That sounds like a huge exam trap.
It is the trap. If a baby is screaming, they are performing a Valsalva maneuver, which increases their own intracranial pressure. The fontanelle will bulge temporarily.
So you can't assess it.
You cannot assess a fontanelle accurately on a crying baby. You have to wait until they settle down, maybe give them pacifier, assess when calm.
And if it's sunken, like a little crater in their head.
Sunken means the tank is empty. It's a classic sign of dehydration.
Got it. Let's talk about the eyes, the red reflex. I thought this was just for fixing photos in Photoshop.
In nursing, it's a cancer screen. It's a need to know that saves lives. You take an ophthalmoscope, you stand at a distance, and you shine the light into the baby's eye. You should see a reddish-orange reflection from the retina, just like red eye in a photo.
That's the normal result. So what's the abnormal, the red flag?
If you see a white glow, the technical term is leukocoria, or if you just see a black spot where the red should be, that is terrifying.
Why? What could it be?
It can mean congenital cataracts, which need to be removed to save vision. Or, and this is the emergent one, it can mean retinoblastoma,
A tumor in the eye.
a fast-growing cancer. If you miss that white reflex on a newborn exam, the child could lose their eye or even their life. So checking for that red eye is technically a life-saving maneuver.
Wow. Okay, now for the classic exam question, the ear pull. I feel like I've heard this 1,000 times, but I always mix it up.
Everyone mixes it up because it's arbitrary unless you know the anatomy behind it. The goal is to straighten the ear canal so you can get a clear view of the tympanic membrane, the eardrum.
Okay, so what's the rule?
It's based on age. For children under 3 years, the canal has a downward curve. So you have to pull the pinna, that's the outer ear, down and back.
Down and back for the little ones.
Correct. For children over 3 years, and for adults, the canal straightens out and moves up. So you pull the pinna UP and back.
I used to have a mnemonic for this. Down for the kids because they are short, and up for the grown-ups because they are tall.
That's a great one. Whatever works. Down for down low, up for tall. Just don't get it backward or you'll be staring at the wall of the ear canal. You'll see nothing and you might hurt the child.
One more core point for hint. The nose. The obligate nose breather rule.
This is so vital and so easy to forget. Infants, especially under about 4 weeks to a few months old, do not know how to breathe through their mouths automatically. It's not a reflex they have yet.
They only breathe through their nose.
They only breathe through their nose. It's an obligate function.
So if they get a simple cold,
It's a potential disaster. If an adult gets a stuffy nose, we just open our mouth and breathe. If a newborn gets a stuffed nose from some mucus, they can't compensate. They can suffocate
just from snot.
just from snot. They will exhibit severe respiratory distress. That's why we are obsessive about using that little blue bulb syringe to suction newborns before they eat or sleep. A clogged nose is a respiratory emergency in a neonate.
Let's do a quick nice to know for hint. The notes mentioned ear alignment.
Right. This is more of a screening tool for other issues. You imagine a line from the outer corner of the eye back to the top of the ear. The top of the pinna should touch or cross that line.
And if it doesn't, If the ears are lower.
If the ears are low set, positioned noticeably lower than the eyes, we start to think about chromosomal abnormalities like Down syndrome or renal anomalies, so kidney issues.
Why kidneys? What's the connection?
It's embryology. The ears and the kidneys develop at the exact same time in utero. So there's a strong correlation that if one is malformed, the other one might be too. Low-set ears should trigger a thought about checking kidney function.
Segment 5. Respiratory and cardiac. You mentioned earlier this is the big one. Why?
Because this is how kids die. It sounds blunt, but it's true. Adults usually have primary cardiac events, heart attacks. Kids almost always have respiratory events that lead to cardiac arrest.
So the heart stops because the lungs failed first.
Exactly. So respiratory assessment is your #1 safety tool. It's the most critical part of the whole exam.
The source material has a great phrase, look before you listen.
Yes. This is a core concept. You can diagnose respiratory distress from across the room just with your eyes. We look for 3 big signs: retractions, nasal flaring, and audible sounds like stridor.
Let's talk retractions. That's when the skin sucks in.
Exactly. A child's chest wall is very compliant. It's made of flexible cartilage, not rigid bone like an adult's. So when they have to pull really hard to get air and creating a lot of negative pressure, the chest wall actually collapses inward. You see the skin sucking in between or around the ribs.
And does the location of the retraction matter?
It matters immensely. This is a huge need to know. The higher up the retraction, the worse the distress. There's a clear hierarchy.
Okay, explain that hierarchy.
So intercostal retractions, that's between the ribs, or subcostal, which is below the rib cage, indicate mild to moderate distress. But if you see suprasternal retractions, where the skin is sucking in right at the little notch in the neck, above the sternum or supraclavicular, above the collarbones,
Yeah.
that is severe distress. It means they're using every single accessory muscle they have just to breathe. That kid is getting tired, and they're about to crash.
And what about stridor?
Stridor is that high-pitched, crowing musical sound you hear on inspiration. It means there's an upper airway obstruction.
Like
Thin croup, or a piece of a hot dog stuck in the throat, or anaphylaxis closing the airway. It is the sound of air trying to squeeze through a tiny straw. It is always a medical emergency until proven otherwise.
moving to the heart. I found the PMI landmarking interesting. The point of maximum impulse. It moves.
It moves as the child grows. The heart sits more horizontally in the chest in babies and young children. As they grow taller, the heart settles into a more vertical position.
So where do we find it? Where do we listen?
For children under 7 years of age, the PMI is usually at the 4th intercostal space, and it's often lateral to or outside of the midclavicular line.
And after age 7?
It drops down and moves in. It goes to the adult position, the 5th intercostal space, right at the midclavicular line.
Exam writers would love that specificity. Under 7 is 4th space. Over 7 is 5th space.
They absolutely do. If you are auscultating at the 5th space on a 3-year-old, you're in the wrong spot, and you might miss the sounds you need to hear.
Let's talk murmurs. I feel like every parent I know has, at some point, been told their kid has a murmur.
They're incredibly common. Something like 50% of all children will have a murmur at some point. Most of them are what we call innocent or functional murmurs.
What makes it innocent?
They're usually soft, maybe a grade 1 or 2. They're often described as musical or vibratory, and a key feature is that they often change or go away when the child sits up or changes position. They are just the sound of blood flowing normally through a small dynamic heart.
So when do we worry? What are the red flags for a pathologic murmur?
We worry about intensity and thrills. A grade 4 murmur or higher is loud, and it is almost always associated with a thrill.
What a thrill. What's that?
A thrill is a vibration you can actually feel with the palm of your hand on the chest. It feels like placing your hand on a purring cat.
That's a great visual. I can feel that.
If you feel a purr, that is not innocent. That is the feeling of turbulent blood flow caused by a structural defect, a hole in the heart, or a tight stenotic valve. That kid needs to see a cardiologist.
Nice to know for this section. The notes mention chest shape.
Yeah, just a quick point. Infants have a round chest. The front to back, or AP diameter, is equal to the side to side, or transverse diameter. It's a 1.1 ratio.
And that changes.
As they grow, it flattens out into the adult shape, where the chest is wider than it is deep. If a 10-year-old still has a round 1.1 chest, that's called barrel chest, and it's a sign of chronic air trapping from a lung disease like severe asthma or cystic fibrosis.
Segment 6, abdomen and genitourinary. We are moving down the body. And we have another one of those order of operations traps here.
Yes. a big one. For the abdomen, the rule changes. The order is inspect, and then you auscultate. You listen second. You do not touch or palpate until after you've listened.
Why is that so important?
Because if you poke and prod the belly with your hands, you stir things up, you stimulate peristalsis, you might create bowel sounds that weren't there, or make them sound hyperactive when they were actually hypoactive.
So you ruin the data.
You completely ruin your auscultation data.
Yeah.
You need to hear the baseline silence or activity before you disturb the piece. So it's look, listen, then feel.
That's a solid rule. What about hernias?
Umbilical hernias, the classic Audi belly button, are super common in infants, especially premature infants. They usually resolve on their own by school age as the abdominal muscles strengthen.
And the old advice to tape a coin over it?
No, don't do that. That doesn't help. And can cause skin irritation. We just watch them.
When are they dangerous?
They're dangerous if they become hard, painful, or non-reducible. Non-reducible means you can't gently push the bulge back in with your finger.
Then that means...
That suggests the bowel has become trapped. We call that strangulated. That cuts off the blood supply. That is a surgical emergency.
What about inguinal hernias? That's in the groin area.
Those are different. They almost always require surgery. They don't fix themselves. And they have a much higher risk of getting stuck or strangulated.
Now for the boys, the testicular exam, this seems fraught with difficulty.
It is. The main thing we are checking for is cryptorchidism, which is the medical term for undescended tests.
And why is that a problem?
Well, the scrotum is designed to keep the testicles cooler than the core body temperature. If they don't drop down into the scrotum, the internal body temperature is too hot for them. It can kill the sperm cells, leading to sterility, and it significantly increases the risk of testicular cancer later in life.
But there's a reflex that makes this exam hard, right?
Yes, the cremasteric reflex. It's an evolutionary protective mechanism. If you touch the inner thigh, or if your hands are cold, a muscle pulls the testicles up into the inguinal canal to protect them and keep them warm.
So you look, and it looks like they are missing, but really they are just hiding from your cold hand.
Exactly. The parent might say, I see them in the warm bath, but not at the doctor's office.
So how do we beat the reflex? How do we get an accurate exam?
You have to trick the muscle. The best way is to have the child sit cross-legged, like Indian style, or in a tailor position. This gently stretches the inner thigh muscle and prevents the retraction. And for God's sakes, warm your hands first.
Segment 7, neuro and musculoskeletal. We are in the home stretch now.
Let's talk hips. This is a big one. Specifically in infants, we screen for something called developmental dysplasia of the hip, or DDH.
That's where the hip socket is too shallow, right?
Exactly. The head of the femur, the ball, keeps popping out of the socket. We use two specific maneuvers to check for this. Ortolani and Barlow, sounds like a fancy law firm.
Ortolani and Barlow, what are we doing?
With the baby on their back, we are gently adducting and abducting the hips, rotating them out and in. You are feeling for a clunk.
A clunk. The notes emphasize not a click.
Right. A soft click is common and usually just a ligament snapping like cracking your knuckles. It's benign. A clunk is a distinct, deep feeling. It feels like the bone physically dislocating and then popping back into the socket. If you feel that clunk, the hip is unstable.
Are there any visual clues we can look for?
Yes. This is a great tip for parents, too. Look at the baby's legs from the back when they're on their tummy. Look at the gluteal folds, the fat rolls in the back of the thighs.
Okay, what are we looking for?
They should be symmetrical. If one side has more rolls, or if the rolls are higher up than on the other side, that suggests one leg is shorter than the other.
And it's shorter because?
Because the hip is dislocated upwards and backwards. Asymmetrical gluteal folds is a classic sign of hip dysplasia.
That's a great visual check you could do during a diaper change.
Okay.
Let's talk about primitive reflexes. These are the ones babies are born with.
Right. The morchodia, or startle reflex. The rooting reflex, where they turn toward a touch on the cheek to find food.
Yeah.
The Babinski reflex, where the toes fan out.
The need to know here isn't just that they exist, but that they have to leave.
Yes, that is the key point. They must disappear. These are reflexes controlled by the lower brainstem. As the brain matures and the nerves get their myelin sheath, the higher brain, the cortex, takes over and suppresses these primitive movements.
So if they stick around for too long?
If a primitive reflex persists past its expiration date, for example, if a 2-year-old who is walking still has a positive Babinski reflex where their toes fan out when you stroke their foot, that is a major red flag.
What does it indicate?
It indicates a neurological lesion or an upper motor neuron problem. We think of things like cerebral palsy. It means the brain isn't maturing and developing correctly.
So, reflexes. Good in babies, bad in toddlers.
Exactly. Their presence is normal, but their persistence is pathological.
Nice to know for legs. The notes distinguish knock knees from bow legs.
This confuses parents all the time. It's a normal developmental progression. Toddlers are often bow-legged. The medical term is genu varum. Their legs are apart like a little cowboy. That's normal for new walkers as they find their center of gravity.
And then what happens?
As they get a little older, around preschool age, their legs swing the other way. They tend to become knock-kneed, or genu valgum, where their knees touch when they stand straight.
There is a great mnemonic for this in the notes.
I love this one. Gum. Genu valgum. Gum makes your knees stick together.
That's perfect. I'll never forget that now. Genu valgum equals gum equals sticky knees.
And finally, a quick note on cerebellar function, which is balance and coordination. For older kids, the school-age kids and teens, we can do tests like the finger-to-nose test or the heel-to-shin test. It looks a lot like a roadside sobriety test, but it's a great quick screen for coordination problems.
Wow, we just ran through the entire body from head to toe. That was intense.
It is a lot of information, but if you focus on those key safety triggers, those need-to-knows, it becomes manageable.
So let's wrap this up. We've covered a ton of ground. If our listener is driving into their clinical shift right now or cramming for an exam, what are the 3 absolute must-haves they should keep in their pocket from today?
Okay, 3 things. Number 1, safety first. Know your respiratory distress hierarchy. Blue hands are okay. Blue lips are not. Intercostal retractions are bad. Suprasternal retractions mean you need help right now.
Number 2.
Number 2, accuracy matters. Don't fake the numbers. Use the right BP cuff, that 40% rule. Pull the ear the correct way down and back for small kids, up and back for bigger kids. Bad data leads to bad treatment.
And the 3rd?
Number 3, differentiation. Know the difference between a bruise and a Mongolian spot. Know the difference between a normal toddler fall and signs of abuse. Your documentation is your defense, and more importantly, it's the child's protection.
That is the core 20% right there.
It really is. If you nail those things, you're on your way.
No, I want to leave everyone with a final thought. We talked about a lot of data today. Charts, numbers, maneuvers, reflexes. But you had a really interesting point in our pre-show notes about the invisible assessment.
Yes, this is sort of the art that comes after the science. We can teach you the science, you can memorize the entire chapter, but the best pediatric nurses, the ones who really save lives, have an extra sense.
What is that?
They walk into a room and they feel the vibe before they even look at the patient.
The vibe. What do you mean by that?
They sense the anxiety in the room. How is the parent holding the child? Are they holding them loosely or with a death grip? Is the parent terrified? Is the parent disengaged and on their phone? Because children are emotional mirrors.
So the parent's state affects the child's vitals.
Directly. If the parent is terrified, the child's heart rate goes up. The child's breathing pattern changes. The data we collect is profoundly influenced by the emotion in the room.
So the assessment isn't just biological, it's emotional, it's relational.
Exactly. The art behind the science is knowing that you are treating a family unit, not just a little body in a bed. And sometimes, if you can calm the parent down, you might just cure the tachycardia you are about to document. Sometimes, the most important intervention you can do is just put a hand on a mom's shoulder and say, "You're doing a really good job. We're going to figure this out together."
That is a powerful place to end. Listeners, take a deep breath. You know more than you think you do. Trust your gut, watch for those red flags, and always, always check the cuff size.
Stay curious.
We'll see you on the next Deep Dive.